Indapamide is a thiazide-like diuretic drug with an antihypertensive effect. It is commonly known as a water pill and is available in tablet and modified-release tablet forms. This thiazide-like diuretic drug is orally available as it follows Lipinski's rule of 5. Indapamide has a molecular weight of 365.84 grams per mole, which is below 500. Indapamide contains 2 hydrogen bond donors, which once again falls below the limit of 5 hydrogen bond donors. Indapamide also contains 5 hydrogen bond acceptors. This follows the rule of containing a maximum of 10 hydrogen bond acceptors. The log P value is 2.2, so the drug is lipophilic enough to cross the lipid bilayer, whilst also being hydrophilic enough to dissolve. This is due to the fact that it contains a polar sulfonyl chlorobenzamide moiety and a lipid-soluble moiety, which distinguishes indapamide's activity in comparison to other diuretics. Now we're going to talk about indapamide's structural activity relationship. Thiazide and thiazide-like diuretics contain a sulfonamide group, which makes them polar and is responsible for the diuretic effect. They also contain a chlorine substituent at the ortho position, which leads to electron withdrawing effects, thus making indapamide a weak acid with a pKa of 8.8. These two functional groups make up the pharmacophore of both thiazide and thiazide-like diuretics. However, thiazide-like diuretics do not possess 2 sulfonamide groups and a thiazide ring. Also, thiazide-like diuretics contain benzene and amide groups, which can be distinguished from our given examples. The methyl group and the near-benzene ring are lipophilic substituents and increase lipid solubility and the duration of the thiazide-like diuretic action of the drug. The amide group in the meta position from the sulfonyl group is an electron donating group. What is interesting is that there is an indolent group next to the amide group, which distinguishes indapamide from other drugs. This single end bond is known to be responsible for direct vasodilation and therefore gives indapamide an advantage of being a good antihypertensive diuretic. Indapamide is used to treat hypertension by regulating blood pressure. Blood pressure is defined as the pressure of blood in the vessels that carry the blood from your heart to the rest of your body. As a general guide, ideal blood pressure is considered to be between 90/60 and 120/80. Below 90/60 is considered hypotension. Above 140/90 is considered hypertension. The Global Burden of Disease 2015 highlights that high blood pressure is the second biggest known global risk factor for disease. Patients with extremely high blood pressure may have the following symptoms: fatigue or confusion, vision problems, chest pain, and difficulty breathing. However, the most dangerous feature of hypertension is that many patients often do not experience significant enough symptoms to be actually aware of their condition. This puts them at severe risk of developing heart disease or attacks or failure, strokes, and kidney disease. So how was the drug discovered and developed? Indapamide's discovery began in the 20th century when Nobel Prize winner Gerard Domark accidentally discovered Prontosil, a sulfonamide dye, when trying to save his daughter from bacterial infection. He found that infectious bacterial cells were inhibited by this dye. In 1936, Ernest Fournier carried out research on Prontosil and found that it acts as a prodrug when it enters the human body. Once in the body, the drug is converted into sulfonamide, which is an antibacterial agent. Further research conducted on sulfonamides found that high doses called alkaline urine, metabolic acidosis, and acidemia. During 1937 and 1938, research on acidemia was done, and researchers discovered that the sulfonamide functional group in sulfonamide had diuretic effects. In 1940, Thaddeus Mann and David Kaelin from the University of Cambridge observed that sulfonamide inhibits carbonic anhydrase. Meanwhile, Davenport found that high concentrations of carbonic anhydrase are found in the kidneys. This discovery also found that only primary sulfonamides possessing the acidic SO2-NH2 act as carbonic anhydrase inhibitors, whereas secondary SO2-NHR cannot. In 1949, clinical trials were conducted by physician William Schwartz to test the diuretic effect of sulfonamides. He gave 3 patients with heart failure high doses of the oral drug. However, this resulted in toxic effects, thus it was abandoned. This inspired Robin and James Clapp to synthesize heterocyclic sulfonamides by adding SO2-NH2 groups to electron withdrawing structures, resulting in the discovery of acetazolamide. It is more potent than sulfonamide as a carbonic anhydrase inhibitor. In 1952, acetazolamide was introduced, but can only be administered periodically as it caused complications inhibiting anhydrase throughout the body. Apart from its complications, acetazolamide is still used for glaucoma treatment. Considering its complications, researchers explored safer diuretic molecules, resulting in the discovery of thiazides in 1957. Dr. Carl Bayer crafted the hypothesis that the main problem surrounding sulfonamide as a diuretic involved its inhibitory action of carbonic anhydrase on the distal end of the renal tubules, causing an increase in excretion of sodium bicarbonate. However, the desired effect was to remove chloride, as it is believed a low-salt diet is effective in controlling blood pressure. He also wanted the diuretic to act at the proximal end to achieve this. His first attempt that involved the synthesis of succinide was unsuccessful, as even though it increased chloride excretion, it continued to increase sodium bicarbonate excretion. He then collaborated with James and Frederick. They introduced a second sulfonamidal group, and this led to the discovery of aromatic sulfonamides, increasing chloride excretion. They then created chlorphenamide, where a chlorine atom was added to the benzene ring. This increased chloride removal and was a more potent carbonic anhydrase inhibitor. However, the drug was already known and could not be patented. Therefore, to change the drug, they added another chlorine to the benzene ring to discover dichlorphenamide. With a goal of finding an agent to increase salt excretion from the kidneys, the scientists continued their investigation, and multiple experiments led to the discovery of benzothiazide. Benzothiazide was more potent, with no increased bicarbonate excretion. This drug was then named chlorothiazide in the report published in 1957. George D. Stevens then created hydrochlorothiazides, which is 10 times more potent than chlorothiazide, and was clinically used in 1959. A year later, Dr. Rubin found that removing the sulfonamide group from the structure removed its diuretic activity, but kept the antihypertensive activity. This discovery of benzothiazides and aromatic sulfonamides gave rise to new diuretic sulfonamides. Indapamide was one of them, and was reported as a diuretic in 1984. The indoline group was added to the sulfonamides to separate the diuretic effects from the thiazide-like antihypertensive effects. At lower doses, indapamide has antihypertensive effects. However, at higher doses, indapamide has additional diuretic effects, hence why a dose of 2.5 mg is preferred. A randomized control trial for the treatment of hypertension was a 1967 VA cooperative study phase 1. In this trial, the group was given active treatments containing hydrochlorothiazides. These achieved an average decrease in blood pressure of 43 in systolic and 30 in diastolic. The results also showed that thiazide-like drugs were associated with a lower risk of having a cardiovascular event when compared to the different types of thiazide diuretics. This is the reasoning behind why thiazide-like drugs, such as indapamide, were preferred for use over thiazide drugs. Another randomized control trial was conducted to compare efficacy of thiazide drug hydrochlorothiazide and thiazide-like indapamide on ventricular and arterial functions in patients suffering from hypertension alongside diabetes. 56 patients were randomly given either indapamide or hydrochlorothiazide, added to an ACE inhibitor, quinapril, as a treatment method. After 6 months of treatment, it had been found that mean longitudinal systolic velocity, longitudinal strain, and longitudinal early diastolic velocity of the patients taking indapamide increased 7%, 14%, and 31% respectively, but did not change on those taking hydrochlorothiazide. The trial results showed that indapamide was more effective at improving endothelial and arterial functions compared to hydrochlorothiazide in patients with hypertension as well as diabetics. This indicates that indapamide has better effects in treating hypertension than hydrochlorothiazide. So how is indapamide synthesized? The main synthesis of indapamide is comprised of 2 separate syntheses, which when their products are combined, ultimately form the drug. These individual syntheses both start off with commercially available compounds. The first synthesis starts off with 4-chlorobenzoic acid. This is reacted with chlorosulfonic acid and ammonia to give 4-chloro-3-sulfomoyl benzoic acid. This product is then further reacted with thionyl chloride to give the final product of this part of the reaction, 4-chloro-3-sulfomoyl benzoyl chloride. The second synthesis starts with 2-methyl-indoline and can be done over 1 or 2 steps. The one-step method involves reacting the starting product with hydroxylamino sulfonic acid. This is an inorganic compound that is formed through a sulfonation reaction between hydroxylamine and a solution of various sulfur-containing acids known as oleum. The end product of this reaction is 1-amino-2-methyl-indoline. The two-step method of generating this same product requires the addition of sodium nitrate and hydrochloric acid to 2-methyl-indoline. This is a nitrization reaction which leads to the formation of 2-methyl-1-nitrosol-indoline. In the second step of this method, the 2-methyl-1-nitrosol-indoline is reduced to 1-amino-2-methyl-indoline using lithium aluminium hydride. Finally, the end products of these reactions, 4-chloro-3-sulfomol benzoyl chloride and 1-amino-2-methyl-indoline, undergo an acylation reaction with sodium bicarbonate, water, and tetrahydrofuran to give indapamide. The site of action of indapamide and other thiazide-like diuretics is at the cortical portion of the thick ascending lumen at the loop of Henle and distal convoluted tubule. At the DCT, the cells contain a sodium chloride co-transporter at the apical membrane, which is oriented towards the lumen, where fluid ends up as urine. The sodium-potassium ATPase, potassium ion channel, and chloride ion channel at the basolateral membrane faces the rest of the body. Sodium enters the cell via the sodium chloride co-transporter and leaves via the sodium-potassium ATPase. This exchanges with potassium, which then enters the cell and is recycled via potassium channels, and chloride is then reabsorbed through the co-transporter and exits the cell through a basolateral chloride transporter. Thiazides act by inhibiting the sodium chloride co-transporter, and this shuts down the movement of all the molecules. This results in the increased renal excretion of sodium and potassium, but decreased excretion of calcium, since thiazides enhance calcium reabsorption. This helps reduce blood pressure, because the drug will increase the amount of salt and water that comes out of the kidneys via urine. An excess of salt within the body results in fluid buildup in the blood vessels, increasing blood pressure. However, thiazide-like diuretics decrease the amount of salt in your body, therefore removing the extra fluid. Increased intracellular sodium stimulates the sodium-calcium exchanger, driving calcium into cells. The increased cytosolic calcium caused by these mechanisms triggers contraction of vascular smooth muscle, leading to vasodilation, which helps decrease blood pressure, further reinstating indapamide's antihypertensive properties. Like any medicinal drug, indapamide has a few on and off target side effects. Indapamide decreases levels of potassium, chloride, and sodium in the blood, resulting in an electrolyte imbalance. When this happens, your body's water levels rise and your cells begin to swell. Therefore, the on-target effects include polyuria. Because indapamide lowers blood pressure by the loss of water via urine, it slows down blood circulation. Therefore, the brain receives less oxygen. Patients may experience side effects such as feeling faint and postural hypotension. Off-target effects of indapamide include mild skin rash. Hypersensitivity reactions occur when the aromatic amine group is oxidized into hydroxylamine metabolites by the liver. This is an irritant to the respiratory tract, skin, eyes, and other mucous membranes. Indapamide also binds to red blood cells, which are broken down in the liver. This can result in abnormal liver function. Therefore, further off-target effects can also include severe stomach pain, sickness, and tenderness or swelling of your stomach. In conclusion, indapamide is a thiazide-like diuretic drug with antihypertensive properties. It is mainly used for the treatment of hypertension and functions through a similar mechanism of action to other thiazide and thiazide-like drugs. We hope you found this video useful. Thank you for listening.